Hi everybody, welcome to Airway Clearance Techniques and Hyperinflation Therapy. This is based on Walsh's Chapter 35, Neonatal and Pediatric Respiratory Care. Today we're going to talk about some reasons for airway clearance techniques, some of the risks of airway clearance techniques, and when we're done with all of this, you should be able to explain those. You should be able to, when we're through, apply various techniques of airway clearance and understand how to avoid risks and complications associated with those techniques. You should also understand the role of hyperinflation therapy and its relationship to proper airway clearance. So let's talk about what is airway clearance. Airway clearance and airway clearance techniques are designed to remove secretions from the lungs. They include postural drainage, percussion, chest wall vibration, and coughing. All of these improve how effective a cough might be or help to get a cough work better, as well as these all share the same goals, which is basically to get sticky, icky secretions up and out of the airway. Old school terms for this are bronchial drainage, postural drainage, bronchial drainage, and even pulmonary toilet was a term that was used. And all that means is just we're going to get icky, sticky secretions up and out of the airway. So we're going to talk about newer techniques and traditional techniques. Traditional techniques, older techniques that were around, yes, in the dinosaur age when I was a therapist just starting out in the 1980s, are postural drainage, which is turning a patient upside down with their head down. We don't do as much of that anymore. Beating on their sides and chest, which is percussion, and vibrating with our hands the chest wall, as well as encouraging a patient to cough. We found that just like kicking a flat tire, those don't tend to help remove secretions and help open up airways. And so we have developed some newer techniques, oscillating PEP, cough assist, high frequency chest wall, compression and oscillation, which is a fancy name for the vest, as well as intrapulmonary percussive ventilation, which is vibrating the airways from the inside out, and also we can give medications with that, and also autogenic drainage. All of those, as well as things like huff coughing, can help get secretions up and out. So how does this all work? Well, there's two main ways. With little cilia, if you think back to first semester, and we talked about airway, the mucous membranes and the airway clearance, we have little finger-like projections, tons and tons of them, that move, that sweep secretions up and out of the airway. The other main way that we move secretions up and out, not just through the gel and sol layer with ciliary movement, but also with coughing. Coughing is a short, fast breath out, where the glottis closes and then opens, expels air, and in a very explosive manner. Expulsion, or getting rid of, it's just a big word for getting rid of mucus, requires a lot of flow from the peripheral airway towards the trachea. Children, especially small children like toddlers and infants, can have complete airway obstruction that can lead to atelectasis and the elimination of expiratory flow. So think about this. You've got an airway, it's got a big fat mucus plug in it. It's a little tiny kid with a smaller airways, and that mucus gets hardened and stuck in there, and they can't get it out. That's when airway clearance techniques may help. So let's talk about some of the traditional airway clearance techniques and some of the newer techniques. So we're going to start with some of the traditional techniques for getting these secretions up and out. Some of the traditional airway clearance techniques include postural drainage, which is just positioning a patient in the correct way in order to move secretions from the small outer airways to the larger bronchi where they can be coughed up and out. It can be used in combination with percussion. Percussion is believed to loosen secretions from the bronchial walls. Percussion is, while the patient is in those various drainage positions, the respiratory therapist percusses the chest wall using either a cupped hand or a cup device, a soft cup device that you see pictured here with this infant. Clinicians shouldn't percuss over any bony areas or over the spine, sternum, the last few ribs, any areas that are sutured, any drainage tubes, kidney, liver, or belly also should be avoided. Anything below in the abdomen, below the rib cage, again, they only want to percuss on the chest. It's rhythmic clapping. It sounds like horse's hooves when it's done correctly. Vibration of the chest wall. Unlike percussion, the clinician's hand does not lose contact with the chest wall during vibration. I usually use two hands together. I place them on one area of the patient's chest, and then on exhalation only vibrate strongly. Now, this is said to help loosen and move some of the secretions into the bronchi. We know that the vest works better than any hand percussion or vibration. Postural drainage, we'll talk about some of the complications of these as well. Also, depending on the position, can have some adverse risks. Coughing. Coughing should be used, can be used after all airway clearance techniques. Anytime you do any postural drainage, percussion, vibration, or any drainage, you should ask your patient to cough strongly. If a patient cannot cooperate, if they're not old enough to cooperate or they're too sick, it is a lot harder to get rid of secretions. I want you to remember that we usually combine both postural drainage and percussion together. PEP therapy can be combined with cough assist, and all of these traditional airway clearance techniques should be followed by a cough. We can also use a vest. So cough, all airway clearance sections should end with a cough. Huff coughing or forced expiratory technique requires a patient to forcefully exhale from mid to low lung volumes with an open glottis. I usually have my patients that are huff coughing try to make a piece of tissue paper held in front. They hold a piece of tissue paper in front of them and they try to make it move with an open glottis, and it's a ha, ha, a huff sound for huff cough. Coughing and forced expiratory technique. One of the most important components of airway clearance is vigorous coughing. We know that in patients with CF and other chronic lung disease, vigorous coughing can be tough, so a huff cough can be much, much more effective. Drainage by itself, percussion and vibration by themselves, or done by hand don't work nearly as well as oscillating PEP and the vest. So most studies have showed that a huff cough can be successful and that it can be effective, especially in more in adolescents and young adults than in younger children. So huff coughing for those CF teenagers can be really, really effective. Various devices are available for positive expiratory airway pressure therapy, or PEP, or oscillating PEP. This PEP therapy uses some kind of expiratory resistor. It creates some resistance when you blow out, coupled with a patient's actively blowing out, and it generates a positive airway pressure, or PEP, during expiration, and in turn opens the airway. So they breathe out against some kind of restriction. There is extra pressure in the airway and it pops open closed airways. This is widely used in Europe, and many parts of the United States are following suit. It's really important in treating CF and bronchiectasis, and to a lesser extent, pediatric post-op patients. There are simple resistors that can be attached to a mask or a mouthpiece, like the flutter valve, the acapella for oscillating PEP, as well as the Quake and the Arabica all work really well. It's been shown in CF that having multiple types of therapy helps with patient compliance, especially in adolescent patients. Cough assist can be helpful. Autogenic drainage and cough assist. Cough assist, or insufflator, exsufflator, but commonly known as cough assist, can be really beneficial in neuromuscular patients. We'll be talking about neuromuscular patients and talking a little bit more about this. Things like muscular dystrophy. Duchenne's muscular dystrophy is one of the more frequent types of pediatric muscular dystrophy. The cough assist allows positive and negative pressures. Then pressures increase, open things up around the mucus, and allows weak muscles the best advantage for creating a cough. It then generates a negative airflow and negative pressure to help stimulate that cough. Not really known if it's helpful in infants, but we know that it can help in kids, especially if it's used in conjunction with a vest or with chest physiotherapy. It can help kids, neuromuscular pediatric patients, get secretions up and out. Autogenic drainage, or AD, is a series of breathing exercises designed to help patients that have bronchiectasis or CF get loosen secretions from the smaller airways and get them up and out. So it moves secretions from the very, very small outer airways to the middle airways, and then helps to increase the how deeply they take a breath in. Autogenic drainage is very simple, and it can be a good self-treatment for patients with CF. Most of my CF patients that I saw were beyond autogenic drainage, but for a normal CF patient, it can be helpful. That brings us to the vest. There are quite a bunch of different inflatable vests that connect to an air compressor. The air compressor produces oscillations which vibrate the outside of the chest, and it loosens and mobilizes mucus. There have been many, many long-term studies that have shown that the vest works exceptionally well for patients with bronchiectasis and with CF, cystic fibrosis. And works much better than manual percussion. So let's talk about some of the complications that you can see with airway clearance techniques. Hypoxemia, especially in infants, is one of the most common that you'll see. It can be related to position, especially in infants, especially if the bad lung is up. Generally, you get better oxygenation with the good lung up and the bad portion, or portion that is damaged, down. When you're doing postural drainage and percussion, however, in order to get it to drain, you've got to have that damaged or atelectatic portion up. And so that can create problems. Atelectasis, vigorous chest percussion has been noted to produce some increased pressure in the chest. That increased pressure can result in atelectasis, depending on the equipment that you use. Bronchospasm can also result if you as you can imagine, if your patient clamps down, it can result in hypoxemia. So bronchodilators prior to any airway clearance therapy may be desirable if your patient has a tendency, like asthmatics, to have bronchospasm. Oxygen consumption, increased oxygen consumption. If there is an increase in cardiac output, if there is increased oxygen consumption, if there is a decreased PaO2, like a low oxygen level on an ABG, then airway clearance techniques may result in hypoxemia. So you have a low oxygen level, just keep an eye on your oxygen saturation. GERD, gastroesophageal reflux. This is a common cause of problems in infants and children. Airway clearance techniques for patients who have GERD. There was a study, one study that the patients with GERD had a 5-fold increase in reflux episodes during airway clearance techniques. And even if treatments were done 3 to 5 hours after feeding, they still had a 5-fold increase in GERD. So your patients with gastroesophageal reflux or GERD need to really watch them and be careful with airway clearance techniques for them. It's rare, but with your head injury patients, you do not want to turn them on, put their head down. You want to make sure that that you are not putting excess pressure into the head, increasing intracranial pressure. Many institutions will not put premature infants or children in a head down position or Trendelenburg position because of increased intracranial pressure, and it's a contraindication in patients with any kind of head injury, concussion or any kind of head injury. You do not want to put them in a head down position, and you may want to not do airway clearance techniques, especially a head down position. So if that's the case, how do we select patients for airway clearance techniques if we have to be careful of some of these complications of doing this? So some conditions where airway clearance techniques may not be beneficial include asthma. Asthma, the first concern should be getting the airway open, not getting the secretions out. So I want you to remember that. Bronchiolitis. Bronchiolitis really is a stuffed up nose, and there were no real beneficial changes when airway clearance or CPT, chest physiotherapy, was used for bronchiolitis. Suctioning the nose had the most benefit for bronchiolitis patients, not pounding on their chest. Pneumonia, there are several studies where chest physiotherapy and pneumonia had no effect or actually spread the infection, especially in adolescents and young adults. So again, it may not be warranted in pneumonia. Post-surgical patients, there can be an increased incidence of atelectasis, and so you really want to watch for patients with that, patients that had deep breathing instruction, that were coughing. Those are things that you want to watch for. Percussion to the right upper lobe every 1 to 2 hours for the first 24 hours after extubation is a pretty common practice for many PICUs and NICUs, neonatal intensive care unit. This is based on a report that claimed a dramatic reduction in risk to right upper lobe atelectasis after extubation. However, it's unclear from the study if suctioning alone or the chest physiotherapy was responsible for the results in that study. So it could be that the patients just needed suctioning. Conditions where it's clearly airway clearance therapy is beneficial. If you have a patient with mucus plugging in the large airway that won't clear with coughing or suction, or they're getting 30 mils of sputum or more a day, this is when airway clearance techniques may be helpful. So one of these is acute lobar atelectasis. This is when an entire lobe is sucked in because of mucus plugging. Mucus plugging may respond to one or more of your airway clearance techniques, depending on what's appropriate for the patient. So chest physiotherapy, oscillating PEP, or the vest can be used for that. Once the atelectasis resolved, then you can discontinue the treatments. The presence of an air bronchogram suggesting pneumonia, you should be cautious when using airway clearance techniques because you may have bacteria that you can actually spread and make the pneumonia last longer. So do be careful about that. Make sure it is truly mucus plugging responsible for the acute lobar atelectasis. Cystic fibrosis, we've known for a long time that oscillating PEP and the vest can be used, and that the more that patients and their parents can do at home or self-care can be really, really effective. So things like huff cough, oscillating PEP, and the vest, as well as exercise, can all be really helpful for patients with CF. Current practices are for patients starting about age 2 to start using a vest as tolerated and working slowly up to 60 minutes in early childhood on a vest. Follow-up and consistency are key when teaching how to do oscillating PEP and PAP therapy and the vest, as well as coughing techniques. Exercise, physical activity has been proposed to be as good as some of the traditional airway clearance techniques. There is no evidence to support or to say that exercise really works. Keep in mind that, for example, aerobic and anaerobic exercise require an increase in minute ventilation with large and turbulent breaths. This allows air to get around and behind some secretions. In addition, there's some positive benefits on the cardiovascular system and the muscles that support the chest. Physical training and as well as pulmonary rehab can be extremely beneficial for CF patients and should be encouraged in anyone capable of physical activity. Frank hemoptysis, empyema, foreign body aspiration, and untreated pneumothorax are all reasons to not do airway clearance techniques. They are considered contraindications or a reason to not do them for all of the different types of airway clearance techniques. So again, large amounts of bright red blood, frank hemoptysis, empyema, a loculated large area of pus, foreign body aspiration because you don't want that foreign body to move down further into the airway, and untreated pneumothorax, all considered an absolute contraindication for airway clearance technique. So how long and how often do you do these different airway clearance techniques? In CF, in the CF centers, it depends on how old the patient are and how well they tolerate, but most CF centers recommend 30 to 60 minutes, depending on the patient. Your book says 30 to 45, so this is where the book and clinical practice may vary. I worked in a CF center. We tried to have our patients on them for a minimum of 30 minutes. Most airway clearance techniques you will do for 15 to 20 minutes. Most are needed only 3 times a day. On some rare occasions, they may be given around the clock or every 4 hours, but most of the time, patients are allowed to rest at night. You should reevaluate the use of any airway clearance techniques every other day, at least, if not once a shift, at least every other day. That means looking at chest x-rays, evaluating your patient very well, and monitoring how much sputum they're getting up with these different techniques. Hey guys, so there are some times when we are going to either modify or not do ACTs. We may withhold ACTs, especially percussion, when a platelet count is pretty low. We may also, it can be withheld immediately post-operative after a trach. We don't want to dislodge that trach. Anytime there's reconstruction of the upper airway, as well as if there's lines post-operatively that shouldn't be moved. We also don't want to do it over any implanted devices, any surgical tubes, like CF patients may have an implanted device or tube planted surgically, so you want to make sure to pad those devices and be gentle around them. We usually do not do percussion in any patient with brittle bone syndrome because we can literally break their bones. They're so fragile. So if they have rickets or osteogenesis imperfecta, we are not going to do percussion in those patients. There are also patients where we don't want to put them in a head down position. This includes those with gastroesophageal reflux, trauma to the head, surgery to the head or brain, and anybody with head trauma or increased intracranial pressure. We also want to be careful and gentle with anyone with abdominal distension or ascites, anyone with a compromised diaphragm, anybody with uncontrolled hypertension, because we don't want, yes, pediatric patients can have high blood pressure. We don't want to increase pressure in the chest and the systemic pressure. Or anyone with severe cardiopulmonary failure, we want to be very, very careful with. And we do not want to put them in a head down position. Infants and small children often cannot perform autogenic drainage or a huff cough, so just be aware of that. We may use gentle chest wall oscillation, but generally we do not use autogenic drainage or huff cough in very, very small patients. So what should you monitor in a patient who's getting airway clearance therapy? One, if they're in PICU or NICU, they're going to be on a monitor. You're going to see heart rate. You're going to see respiratory rate. You should be looking at breathing pattern. Is it shallow? Is it deep? Is it fast? Is it slow for their age? How's their oxygen saturation? Are they on oxygen? Do they need to be? Is it dropping? Is it changing? These are all things that you need to watch. How's their skin color? Make sure that you're watching skin color as well. So that is important when you're assessing therapy. You should assess pre, during, and post airway clearance therapy. Make sure that breath sounds are assessed before and after every treatment, and the amount of sputum is documented and the consistency. Make sure if the patient complains of any difficulty breathing or chest pain, make sure, or you don't get any, they're unable to get up, secretions, make sure all of that is documented. Make sure that if their skin color changes, make sure that you document that as well. If they become pale, they become red in the face, all of that should be documented. So assessment of therapy includes heart rate, respiratory rate, breath sounds before and after. Make sure that you note whether or not that the patient is on an IV, whether or not they are drinking. Make sure any increase or decrease in sputum is noted. And again, breath sounds before and after, and all vital signs should be monitored before, during, and after treatment. Make sure you're looking at that chest x-ray. Chest x-rays are usually done not every day if they're not on a ventilator. So if a chest x-ray got all, showing atelectasis, got all of this going, and you've been doing it a while and it seems that things have resolved, you can ask for another one. How do you know if your goals have been met? Your patient has gotten up and secretions have been improving in color, consistency, and amount. If their breath sounds improve after, they go from being really coarse to being clear. If their oxygen saturation improves after. If they have an improved chest x-ray, make sure those are noted. It may be time to stop therapy. Also, how are they breathing? If they're breathing easier, again, if you've been doing ACTs for a while, airway clearance therapy for a while, it may be time to stop. What do you document? What are you going to chart about? You're going to chart what you did. So what technique did you use? Was it oscillating PEP? Was it the vest? Which lobes were treated? What was the position of the patient? Were they sitting up? Were they in Trendelenburg? Were they flat? Make sure that you note the position. If they required suctioning, make sure you note that, whether it's just nasal suctioning, oral suctioning, or NT suctioning, make sure you note if you had to suction the patient. Make sure that you document pre and post breath sounds, so that means you've got to listen. Make sure that you document vital signs, heart rate, respiratory rate, an amount of sputum, and what the sputum looks like before and after. All of this should be documented in the chart for each treatment. Here you see nasal suctioning being done with a little sucker to clear secretions from the nose. So let's talk for a minute about one of the newer techniques, intrapulmonary percussive ventilation, or IPV. So how is it done? The It is a treatment that delivers rapid, small bursts of air to the lungs. It helps to loosen and mobilize trapped secretion while opening up collapsed lung areas. It recruits hard-to-reach areas of the lungs, and it can even deliver medication with an integrated nebulizer. Air pulses can be delivered via a mouthpiece, a face mask, or even in line on a mechanical ventilator or to an artificial airway like a trachea, a trach tube. The standard treatment lasts about 15 to 20 minutes, and it can be used in hospital settings like ICU or at home. So who benefits from this? What are the indications? Common conditions that benefit from IPV therapy include cystic fibrosis patients, bronchiectasis patients, neuromuscular patients like cerebral palsy, and ones that have a weakened cough muscles. Also, acute atelectasis can benefit from it as well. Some complications include barotrauma, so over distending the lungs, or a rupture like a pneumothorax can happen as well if the pressure is too high that's created. You can get hemoptysis, bleeding in the airway, or bronchospasm, or even secondary to the bronchospasm, some hypoxemia. Reasons why you may not want to do this: untreated pneumothorax, a patient with blebs or bullae, that's really thin areas on the outer surface of the lungs. If they have an unstable chest wall, like multiple rib fractures, this may not be the best for them. Or if they have pulmonary bleeding, IPV oscillations can cause the clots that form to move. So it's not a good idea. It's a contraindication in that case. Monitoring, you need to assess before and after treatment, all the vital signs, the pressure that you used, the machine controls you used, if you gave any medications, how much sputum was produced, if the patient was cooperative or could be cooperative, and how they tolerated it, and how long the therapy lasted. You also need to document any complaints or adverse reactions. So IPPV, intrapulmonary percussive or ventilation, or IPV, is designed to treat both active pulmonary disease and prevent development of disease caused by secretions getting stuck in the airways. Thank you so much for listening to this video. If you have any questions, please reach out and email me. Have a great day. Thanks.